The information provided on this podcast is for general informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your qualified health provider with any questions you may have. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. Reliance on any information provided here is solely at your own risk.
Welcome. This is Birth, Baby. Your hosts are Ciarra Morgan and Samantha Kelly. Ciarra is a birth doula, hypnobirthing educator, and pediatric sleep consultant.
Samantha is a birth doula, childbirth educator, and lactation counselor. Join us as we guide you through your options for your pregnancy, birth, and postpartum journey. Thank you to our listeners for your continued support. If you enjoy our content, please be sure to like, follow, rate, and review wherever you listen to podcasts. This helps us gain visibility to other people that could benefit from listening in. Hello, everyone. Today we are going to talk about epidurals, which I think a lot of people think that doulas only support people that don't want epidurals. So I think this is maybe surprising for some people that we're going to talk about this. But if you want an epidural, get an epidural, and we're going to talk to you about what it's like so you can know.
Yeah. So we're going to talk about what epidurals are, how they're placed, what's in them, all of that good stuff, just some general information. And then we're going to talk about how you can kind of combat some of the downsides of epidurals, as well as how doulas can support in epidurals. So hopefully after listening to this episode, you'll have a really good idea of what the epidural is, how it can benefit you, how it can maybe be a little bit of a disadvantage, and how you can work with it to make it work for you. So let's do it. Let's talk about it.
Do it.
Let's do it. So let's talk first about how epidurals are placed. So I think what would be helpful is maybe if we walk through kind of what it looks like when you say, I want an epidural. What has to happen in order for that to happen?
When you say pineapple.
Pineapple.
That's
right.
My code word. That's the code word for somebody who changed their mind if they didn't want an epidural and they're like, game over. I decided I do. They say pineapple. And then Ciarra says, hey, nurse, could you call the anesthesiologist and let them know that we want an epidural in room blah, blah, blah. And any chance that you could bolus that fluid real quick? Because they usually need to bolus a bag of fluid. Bolus means make it go fast and get you a full bag of fluids before they, I just got really distracted because Samantha took a drink and it gave us a thumbs up on because she has an apple. So those of you on YouTube.
Get that bag of fluids.
So you will get this full bag of fluid, and what they're doing is they're trying to kind of pump up your blood pressure a little bit because an epidural can drop your blood pressure. So they've got to get that full bag of fluid in you, and anesthesia usually takes a little bit to come in because they're doing other rooms or whatever. Sometimes they don't only work on labor and delivery. In some hospitals, they're working in other units as well. So it really depends on the hospital that you're at. And then they are finally going to get that bag of fluids in you. They're going to sit you up and they're going to kind of move the bed that you're on so that you're sitting in the middle of the bed and facing one way with your legs hanging off, and usually move the bed up kind of high because depending on how tall the anesthesiologist is that comes in, it might be a CRNA or could be an actual anesthesiologist. And then somebody is going to stand in front of you. So they're going to have you scoot your booty, that's just what I say, scoot to the edge of there and have you be rounding your back out like a mad cat is what they oftentimes say. Mm-hmm. And somebody will be in front of you, usually with pillows. Sometimes a nurse is the one who wants to do this, and they're real serious about being the one to stand in front of you. Sometimes your partner can, and sometimes partners are like, no, thanks, opt out, unsubscribe. Mm-hmm. I want the doula to do that. And then we will do it, or the nurse will do it.
And sometimes generally, the partner has to be seated too. Yes. That's one important piece. The anesthesiologist always likes to make sure that dad or partner, whoever, is seated on a chair. So that way, if you get a little bit woozy from the whatever's happening back there, you're not going to hit the floor. Sometimes they say that about doulas too, like they want us seated, or maybe they only want one person in the room. But for the most part, at least around here, they're pretty chill with letting doulas be in the room and letting us do what we want.
Sometimes it depends on the hospital.
Yeah.
So that is something that you should know as the person getting an epidural is that if the anesthesiologist wants everyone to leave the room except for the nurse and your partner, you can try to advocate for your doula staying in if that's important to you. Maybe your partner feels like they need the doula there still. That's fine. I usually preemptive strike. And when the anesthesiologist comes in, I know that a lot of them only want one person in the room. So I will say, or one support person, I should say, in the room. So I will say, hey, doctor, whatever, because they'll say, oh, Dr. So-and-so's here. Hey, doctor, whatever. I am their doula, lots of experience, been in lots of epidurals, but I know some doctors only want one person in here. Do you mind if I stay? And because I asked them and I put them on the spot, they oftentimes just let me stay. I think I've only been asked one time to leave a room, and it was at one time like years ago. So, but I hear about other doulas being asked all the time here, and it kind of stinks. So if you really want them to stay, you can actually talk to your doula beforehand or have them listen to this episode, and they can try to work that out. They are going to, you can take over. You want to start talking about when they clean up the back and do all the draping and everything?
Yeah, so they have you sit in that position where you're kind of like angry cat over a pillow. It's like you're trying to push your back out to the anesthesiologist because we want to, you can imagine what your spine looks like. They want to create as much space in between your spinal, whatever they're called, pieces of your spine. They want to create a lot of space.
Ciarra's grossed out. They'll stop talking about it. Move on.
Exactly. So then once you're in that position, they're going to clean up your back with some cleaning solution. It's kind of cold. Sometimes it's like orange. It's like a betadine sort of thing. So it's like orangey. And then they put a giant plastic sticker on your back with a hole in the middle so that they know exactly where they're trying to put the epidural into. So epidurals go into the epidural space in your back, in your spine. There's different kind of sections of your spine. They want to go into the epidural space. That's where that's going. So once they have your back all cleaned up, they know where they're going. They kind of like push around to see where the best place is on your spine. There's like a couple of different places that they could put it. So they want to figure out what's best for you. And then they start with the process. So they use lidocaine injections to numb the area. So like a topical anesthetic. So they'll give you a couple shots of that. They'll wait like 30 seconds for that to take effect. And then they'll get started with the epidural needle. The epidural needle is a larger needle that they insert a catheter through. I think this is fascinating. Ciarra's grossed out by all of it, but I think it's super cool to watch. So when the anesthesiologists like let me watch, I get super excited. So they have this kind of larger needle that has like a hole in it, and then they insert the catheter through that needle and into the epidural space. And once they feel good that it's there, then they'll take the sharp needle out, leaving the catheter there. And then they give a test dose to see how you're feeling, which
this is the coolest.
Yeah.
This is the coolest thing because some anesthesiologists come in and they give you a lot of information about what they're doing. Some people receiving it are like, no thanks, opt out. I don't want to hear it. But I've been in a lot of epidurals, and I was in one about 6 months ago, maybe, where the anesthesiologist was explaining what she was doing. And when she gave this test dose, she said what it was and then asked some questions. And I, until then, had always thought it was like your first dose, like the test dose to make sure that it's going into the right space, but like that you're going to feel it and it's your first little bit of medicine. I thought that's what it was. I didn't realize that it's not the pain medication at all that they're using for anesthesia. It is a medication that they're putting in there. And if you have a certain reaction to that, they know it's not going into the right space, and then they don't put in the actual medication. And I couldn't believe that in all of the epidurals that I've been in, no one has ever explained that. Not informed consent, right?
Yeah. Yeah. So they're looking for like certain reactions. They want to see what's your blood pressure doing. So they always check, the nurse always keeps track of what your heart rate is right as they're doing the epidural and what your blood pressure is right as they're doing it. And then as soon as that test dose goes in, they check it again and see where where it's at to see if your blood pressure has dropped. Because if your blood pressure, we talked about like the fluids, sometimes the epidural can lower your blood pressure quickly. If that happens, then they want to wait and probably give you more fluids and maybe check the placement. And then they want to see, they ask, like, do you have like a metal taste in your mouth or ringing in your ears or like feelings down your leg or anything like that? And if you do, then they'll, maybe they'll try replacing the epidural. Sometimes they just like wiggle it around. That's going to make Ciarra go ew.
Such a whip, you guys. Trigger warning. We need to add a trigger warning at the beginning.
They do all of that. And then once they are sure that the epidural is in the right place, they are going to, so like there's that little catheter that they put the testos to, they fling it over your shoulder, and then they have you lay down on the bed. So there's no longer anything sharp in your back, just a really tiny flexible tube. I think a lot of people think that there's just a needle like chilling back there. Not the case. It's just the catheter. So they have you lay down flat on the bed. Epidurals work best by gravity. So we want to make sure that you're flat so that that medication can flow all through your body. They also want to make sure that you're a little bit tilted because, as you probably know, if you're listening to this, you can't lay flat on your back when you're pregnant because that can poorly affect your baby. So we don't want to do that. So they'll tilt you just a tiny bit, but keep you as flat as possible where it doesn't interact with baby. And it takes about 20 minutes for the epidural to take full effect. We call it like the sunset of.
I like to say that. I say it's a sunset, not a light switch. So it's not just going to turn everything off. You start to feel less of the beginning and less of the end. So it starts later and it ends sooner, but you still feel the peak. And then eventually you're not feeling the peak anymore. And you're just talking and we're like, oh, there you are. There she is after however long that we haven't seen the not labory you. Real quick, I want to go back to something that's important for partners to know and for two things. One is that if you are the partner and you're supporting the person as they are, angry cat back and leaning on you, it's really hard to not wrap your arms around them because you're used to kind of hugging them in that position if they're there, but you can't touch their back. It's a sterile field at that point. So they will warn you of this, but just giving you a heads up ahead of time. And then also I have a lot of people in labor that are getting an epidural. They're really freaked out. Like, I don't know how I'm going to be able to sit still. There's no way. Like, I can't even sit still right now. How am I going to do it when they're putting a needle on my back? And they freak out about it. There is a very short period of time that you actually have to stay still. And if you feel a wave or contraction coming on, you can say, okay, hold on, I'm feeling a wave before they're doing that. And then they can try to do it in between waves. It's really only like 30 seconds that you have, or to a minute, that you have to be super duper still. So if they're doing that between a wave, you're all good. If one comes on in the middle, it's okay. I promise you, when a mama wants an epidural, she's real good at sitting still, a lot better than she thought she might be.
We've had people in transition or even pushing get epidurals and they're able to sit still through it. There's some sort of mind connection that happens where your mind is not going to let you move. So definitely that. So once you're laid down flat, they hook you up to like the bag of the real medication that goes in, and then you start having that sunset effect. So that medication is given through a PCA pump. So that's a patient-controlled something. I don't know what the A is, something or another.
Administration, maybe?
Sure. Yeah.
Sure. We're going to go with it.
That. We know what we're talking about. So it's given through this pump. It has a continuous flow of medication that is always going to be, that's going to be going the whole time that you are hooked up to the epidural. And then it also has the extra juice button. And so it's like this little button that you can hit if you feel like maybe they're getting a little bit stronger and you're just feeling them a little bit more. Or maybe you've been laying on your left side for a long time and then your right leg that's on top has started getting some of the feeling back. So then you roll over to your right and you push the button to send a little bit more so you can get ahead of it more quickly.
PCA is patient-controlled analgesia. And the reason that this is different than the IV, like, because they could potentially give it like through an IV drip, right? But they don't. They put it on this little machine, like she said, so that you can push a button to get more of the medication if you are having kind of breakthrough. But it does give a constant stream of medication, even if you don't push that button. And there is not, you cannot over push that button. So it does lock you out if you do it too many times within an hour and you have to do it like every 10 minutes. You can only do it every 10 minutes or something like that. So don't worry that you're going to give yourself too much. And I did have somebody think they had to push it every time. They didn't hear that part when we said that it's giving it to you continuously. She thought just if I don't push it, then I'm not getting anything. So
I've had people who just like, that's just like their comfort mechanism is just to keep pushing the button. And that's fine. You will get more. So, if you're wanting like just kind of a light epidural that you're still going to feel, like when it's time to push and all of that, then maybe you want to avoid the button at least towards the end. But if you want to keep pushing the button, then you do you, but we'll just be holding your legs up the whole time. That's fine. So what medications come in the epidural? So I talked about the lidocaine. The lidocaine is what they do to kind of numb the area before they insert the epidural. And then there's actually a lot of different kinds of medications that they can use in the epidural. And what they're using is generally up to the anesthesiologist. So they might be using something called bupivacaine. They might be using some version of morphine. They might be using some version of fentanyl, not the fentanyl that you hear about on billboards, but the actual medical fentanyl. They might be using some combination of different medications. So if you want to know what is in your epidural bag, you can ask that. I've had people that feel really strongly about not having certain medications. And they can ask that, and most of the time they can accommodate those requests as well. So, if that's something that you want to know, absolutely feel free to ask it. I know there's like new research being done all the time about what medication is going to work best. The goal with the epidural is to make it so that you are not feeling the pain of your contractions, but you feel that they exist, because we want you to know when you're contracting for when it's time to push. And we want you to still be able, like a really good epidural, you can still kind of move around in the bed, which I think goes into our next topic, which is what comes with an epidural.
Oh man, so many things come with an epidural. And again, with the medication part, like please don't freak out if it's fentanyl. It is fentanyl, but like the amount that they're using is so small, and it's not like you're thinking. So I know that that's a big thing right now. And like she said, if you just are like, but anyways, I don't want it, then it's fine. Don't get it. And we don't want you to be freaked out or like scared or uncomfortable with something going into your body, because we have had families that have a history of addiction in their family and things like that. And they're like, no, I don't want that anywhere near me. And that's okay. You can always advocate for that. So you can ask beforehand. But the reason that they use those combinations is because it actually helps them give you less medication and get more coverage in some of these situations. So I think that that's really important to just remind you of.
Yes.
As far as what else comes with it. So once you finally have all over coverage, or at least hopefully have all over coverage from your epidural. And again, it's not going to get like your chest. You're not going to feel numb up here. I don't know if it was you or someone else said that they had a client who was not moving their arms and kept asking people to like, can you get me a drink? Can you get me this? Can you get me that? Can you like change the remote on the TV? And after a while realized that she thought her arms were numb.
Oh, no.
She didn't know. She just thought her arms were numb. So she was just sitting still. I'm not laughing at her. It's just like, oh my gosh, like I can't believe, poor thing.
She hadn't moved them so long. Oh,
she just didn't even try because she thought they were. Isn't the mind so powerful?
yeah.
So you should only be like from belly down, numb.
Yeah.
And
wherever they insert it, whatever space in the spine it goes in, that's going to be
they're
numb.
down.
They're down.
Yeah. So then, and they'll do some tests, right? So sometimes they'll be like, is this cold on your leg right now? And they're using like a little alcohol swab thing. Is this cold? Is it cold here? How about here on your cheek? Okay, it is cold there, but not down here. And so they're trying to see if you have all over coverage. They do that with a cesarean too, but they even do it when you're just in a room having a vaginal birth and choosing an epidural, because they usually wait to give this next thing until then. So right away, they're going to do your blood pressure. They're going to be doing it, I think, every 5 minutes at first, and then every 15 minutes. And then you just keep it on for the rest of labor because they do need to do it because it can have an effect on your blood pressure. Mm-hmm. And then the thing that they were waiting for and trying to figure out, if you're feeling the cold sensation is a catheter. So we talked about a catheter going into your back, and that's the little tube. But here we're talking about to get your urine. So they place a catheter into your urethra to be able to go up into your bladder and drain your pee so that you're not having to pee anymore. That's like, I'm like, can I get one too? Can I get a catheter so I don't have to get up and pee 1,000 times? That'd be great. When they give you that, they tape it to the inside of your leg and it just stays there. So it's not going to be able to be pulled on, tugged on, because that taped down thing is making it so that it's not just pulling on that space. I will say it's really not that painful for most people to get the catheter, even if they don't have an epidural. It may be a little uncomfortable, like a tiny little pinch, but it's really not usually a big deal for people. Some people are kind of afraid of that piece. So I wanted to touch on that as well. Yeah. And then, you can get up and like sit up in the bed, but you don't get up and walk around. Now, this is different places too, because there are some places that give what's called a quote unquote walking epidural, where they'll let you go sit on the toilet to labor, to use gravity or whatever, even though you're not needing to necessarily pee. And they kind of do like a very light, and it is put in a different space when they're doing a walking epidural. So it's not exactly the same. But most places just give a regular epidural. So you're not getting out of bed anymore. We call it like rotisserie chickening. You can go left, middle, right, middle, sit up, lay back, left, middle, And so they're never lying you directly on your back. You may get up and do kind of a princess pose sort of thing, or like thrones position where you're sitting up straight. Those hospital beds are so cool. They can move all sorts of ways. If you get an epidural, whether or not you have a doula there or not, you can have them, even the nurse help move your chair or your bed around so that you're not just sitting stagnant in one place. Mm-hmm. You can also ask for a peanut ball to help you be in different positions. So just because you got an epidural doesn't mean you're just sitting still the whole time and not moving around. We actually want you to be rotating and moving around. Yeah. And then you'll also have to have a continual IV at that point. So if you were someone that was taking fluids orally and just had the HEP lock in or saline lock or whatever, but you were not getting fluids in, once you decide you want an epidural, they bolus those fluids that they're now adding to it, and you have to keep that in for the longevity of the time.
Mm-hmm. Yep, absolutely. And different places will have different kind of rules and stuff. Like some places do like what they call an in and out catheter. Well, they'll just come in periodically and drain your bladder and then remove the catheter. Others put in that like Foley catheter that kind of stays there the whole time. And then, same thing with movement. Different places are going to have different restrictions on movement. We heard for the first time someone had a epidural here in Austin where she was able to get out of bed with it, which was crazy. It never happens, but that's pretty common on the West Coast. That's much more common than it is here on the West Coast. So very, very location dependent on that one. And then I think, as we're talking about epidurals, she was talking a little bit like the progression with epidurals and how we want to, continue movement. But I think it's good to talk about the pros and cons, because what some people imagine as the pros and cons may not apply to you in your situation. Some people who really, really, really do not want an epidural maybe really, really need an epidural at some point during their labor. And, sometimes it's the opposite. Sometimes we have people that the only thing that they have on their birth plan is that they want an epidural as soon as they can get one. And then for some reason or another, they can't get one, or maybe it doesn't work as well as what they had hoped for. So let's talk for a minute about kind of some of the pros and cons of an epidural. We'll start with the cons and then we'll go to the pros to end on a happy note there. So I think one of the cons of an epidural is that it does restrict your movement. Once you have that epidural in place, one, you're hooked up to a lot more monitors. We got to have baby on the monitor the whole time because, we need to see how they're reacting to the medication and the different things. And then they want to have your contractions on the monitor so that because you may not be feeling them in the same way. So we want to make sure that they are continuing.
And how your baby's reacting to them. So if you were somebody that wanted intermittent monitoring, that game over for that.
Yep. So you'll be on the monitor. more. We do know that continuous monitoring does lead to higher rates of cesarean deliveries. So, just by nature of being on that continuous monitoring due to the epidural, you are raising your risk of a cesarean. We also know that the movement portion is also really important for progressing labor. Gravity helps labor to progress. It helps your baby to continue to move down. It helps your body to be able to move more easily. And once you get the epidural, especially if you've been laboring for a long time, a lot of times people just want to chill out and do nothing. And so your instinct is to kind of just like, oh my gosh, like I can actually relax now. And then we relax so much that the waves start spacing out. And then maybe we have to start thinking about augmenting labor with Pitocin or whatever else.
I also find that my clients, when they finally are like, oh my gosh, especially if it was like a not planned, maybe epidural, if they get it and then they're just like, they were so exhausted, they kind of fight me a little bit more on moving them around. They just are like, I don't want to. Like, I don't want you to switch sides every 30 minutes. I'm sleeping, or every 45 minutes. And that's a bummer because it can be detrimental.
Then we add,
I mean, that sounds strong, but
well, then you're adding hours to your delivery, and depending where we're at in the labor, sometimes that can be a big problem. Sometimes it's not. Sometimes adding 2 more hours to your labor isn't going to be the difference between augmentation or cesarean and not, but it could be. And so we just need to know when we're getting it, why we're getting it, what is the purpose behind it. So movement is still going to be really important. And then I think one of the other cons to an epidural is that while I don't necessarily, especially people who get epidurals, when they're pretty well established in labor, I don't necessarily see it slowing down labor a whole lot. I do see it slowing down pushing quite a bit, though, because pushing is that stage of labor, that second stage of labor, is such an involved process, and there's really such a mind-body connection. And when you don't have that connection to your body anymore because you can't feel it in the same way, it can be really difficult. And this is especially true if the epidural is really, really heavy, and maybe you don't have as much movement, you're not feeling as much pressure. So I think that's where I see, when I see people who pushed for hours and hours, more than likely they had an epidural. Sometimes that's not the case, but the majority of the time that is the case. And so we have to be a little bit more creative. We have to maybe be a little bit more intervention-y. Maybe it's that, normally we prefer hands-off. Evidence supports like hands-off during pushing. We don't want people like doing perennial stretching or having their fingers in there and introducing more bacteria. But maybe with an epidural, it is more beneficial to have, at least a few pushes where we are pushing, like with providers' fingers there, trying to show them where to direct that energy at. It also, again, going back to movement, it limits your movement. So if your main goals are to avoid tearing, the way to do that is to avoid putting on your back. But with an epidural, that's the easiest place for you to push because getting into other positions can be more difficult. So then we're just more limited in what options are available to you, as well as what your provider is comfortable with. I have people all the time with epidurals who do still have pretty good movement of their legs and could get into, a hands and knees position, or maybe a like modified squatting position, but their provider's just not comfortable with it because they don't feel like they have full control over their body. So I think that can be very limiting as well. That's where, for sure, the advocacy piece comes in really strong in advocating for what you want versus what your provider's comfortable with at that time.
Yeah, absolutely. So there are definitely times when people end up needing to get an epidural and that wasn't what they had planned. And so let's talk about what that might look like and why. Maternal exhaustion is usually the biggest one.
Huge.
So even if you're not like, I'm not in too much pain, I'm just stinking exhausted. And then what we risk is that mom is exhausted and then her uterus is exhausted, that muscle is exhausted. So it's having a harder time sometime even creating those contractions. And then eventually, if mom's exhausted, baby can get exhausted. And so that is kind of the downside of a super long labor. So if you're getting an epidural because of maternal exhaustion, and that wasn't really your plan, the pro here is that could potentially salvage a vaginal birth. That could save it. And sometimes as the doula, we're the one saying, hey, I know this wasn't the plan. I know this wasn't the plan, but I think that this is what we need now. Because here, it might be this versus cesarean if we can't keep this going. So that's something to consider. Other pro is, you get to sleep. You're like going into labor, going into parenthood less exhausted. Hey, that's nice, right?
Yeah.
If you got to have a nice nap before you had to push, great.
Pushing too, like having some energy for pushing is important. And if you've been in labor for 48 hours or something crazy, you're exhausted. I don't care how well you've been handling it. You're exhausted.
Yeah. And then one of the pros is one of the opposites of the con. It's like the commercials where like, you might get diarrhea or constipation. Labor can slow down with an epidural, but labor can also take off with an epidural. So sometimes if you're just so stinking tense that you couldn't relax at all and you've just been clenching and like you're fighting your cervix opening, sometimes we get an epidural and wow, it's magic. We're complete within a few hours, whereas we've been at 4 for 8 hours, 4 centimeters for 8 hours. So there are definitely some perks to getting an epidural too.
Yeah. Especially sometimes like we'll see this if baby's in like a funky position, like if we have a baby that is just really persistently staying in that OP or sunny side up position, and we have done everything we possibly can to try to balance the body and encourage that movement, and baby is just like, sometimes we get the epidural and your body just kind of relaxes and then your baby's like, oh, okay, great. Or maybe it's that you get the epidural and suddenly you're comfortable enough for me to do a sideline release on both sides. And once we do that, it's like, oh, okay, we're flipped and actually let's just have a baby now. I see that happen. I mean, it's happened so many times. So sometimes if you're in that, even though it isn't your intention to have that epidural, sometimes that can be really, really helpful to just have that tool in your toolbox. That's what we always say. It's a tool in your toolbox. We don't have to pull it out, but it's there if we need it.
Yeah. So I hope that this really kind of cleared up some of maybe your concerns if you were nervous to get an epidural, or maybe you don't want one more now. I don't know. I don't care. I'm glad you have the information because, we're all about informed consent here. So if you have any topics you want us to talk about, please do reach out. We love touching on things that people want to know about.
Awesome. Bye, guys. Thank you for joining us on Birth, Baby. Thanks again to Longing for Orpheus for our music. You can look him up on Spotify. Remember to leave a review, share, and follow wherever you get your podcasts. See you next week.